that I am very passionate about personally as well, and I'm looking forward to sharing with you all the advancements that are being made by super specialized hospitals like ourselves in the field of oncology. How are we looking at managing this disease much better? What is the role that we and our teams play, which is different from what a multi-speciality and super speciality hospitals do? So to begin with, I wanted to take you through what cancer care really meant in the past and what cancer care means now. Now, since all our hospitals are located in India and based in India as well in Bangalore, much of this is in context of India, but a lot of it also applies to the larger scale at a global level of how the disease is being managed and the innovative therapies that are coming these days. Now, in the past, cancer care really meant primarily treating basis histology, basis location, very few biomarkers. There were a lot of geographical constraints as well. There were roughly 200 fewer treatment options than what we have today, definitely in India and also at a global level. Only basic modalities were available at the time of surgery, of chemotherapy, of radiation. Radiation actually only came to India around 2 decades back, and primarily linear accelerator. And then some of the more advanced cancer hospitals like ours have advanced radiation therapy equipment and modalities available now, like CyberKnife. We are coming up with adaptive radiotherapy. Those are newer innovations. Very few supportive care options, but they're really the point of view that clinicians and delivery organizations took for cancer treatment really was to add a couple of years to a patient's life. And there was absolutely no focus on quality of life. It was all about making them live a few years longer in whatever way possible. But now that has completely changed. Stage 4 and terminal patients at the time had very limited or no options for care, which is now drastically changed with all the innovative therapies that are there. There was limited or no research or innovation done for targeted drug therapies, gene therapies specific to patients. But now, if we look at cancer care with a global perspective and also with what is happening in India, we know that there is use of proper staging, there is molecular imaging that we do, which has really brought about a paradigm shift in diagnostics. We do less of chemotherapy now, and we try to do more of targeted therapy, which is patient specific, which is very data driven, and which focuses on increasing quality of life. Not just adding years, but adding quality to the years that the patient will be living. We have high-end diagnostics now, and we have a multidisciplinary approach. And I will expand on that in the coming slides as well. But multidisciplinary really means that there are no silos or no isolated prognosis and care plans that are made. We have clinicians across specialties, subspecialties, modalities that sit together, go through the patient's diagnostic reports, patient history together, meet with the patient, family, counsel them, and using a cohesive, concerted approach, make a plan which is multidisciplinary. So we have organ-specific teams of oncologists, we have the surgeons, we have medical oncologists, radiotherapists, nuclear medicine doctors, radiologists, all specialists, one or two from each of the pertinent teams coming together, really, and taking part in prognosis and care plan of the patient and then explaining this to the patient. So this is something that really sets us apart in cancer treatment of patients from what a super specialty, a multi-specialty hospital would do, what perhaps the governments are doing across the world in terms of public health management of this disease. The other thing which rewards a mention and which is happening now is gene-specific therapy rather than organ-specific. Organ-specific was a big breakthrough in its own way about 10 years back, about more than a decade back. Today, we have teams of specialists who look at tumor or cancer in every organ of the body. So we have a hepatobiliary specific team. We have a GI specific team. We have breast cancer team. We have brain cancer team. But now the focus, the emphasis is on more precision in diagnosis and therefore more precision in treatment. And the most precise treatment today that we all are looking at is gene specific rather than organ specific. A lot of research and innovation in this field. We are using this a lot for diagnosing our patients, advising treatment protocols, and then there have been advancements in radiation therapy technologies, in AI powered diagnostics. We are the first in India, at least, to use metaverse mixed reality for proctoring surgeons across the country, where it's really a 3D interface in real time that's available to a patient sitting in a big city, who can actually annotate real time in space and advise step by step to a surgeon who's in operating theater in another country, in a smaller country, in a tier 2, 3 town, and can live proctor the surgery while physically not being present in the same operating theater. So this is something that we're doing now, and there's only more of exciting technology to come in this field. Next, again, to summarize and bullet and emphasize on advancements in diagnostics and treatment. Diagnostics, of course, I spoke about molecular imaging, which is a smart basis of diagnosing most of the patients. We also do a lot of genomics. I think gene-specific therapies, drugs targeting, genome-specific, gene-blocking drugs are something that are coming up big in India. We're advising that for a lot of our patients. We also do digital pathology. Digital pathology essentially helps us cover our entire network of patients across India. We have a footprint in all parts of the country, in small towns, cities, big cities, and digital pathology helps in reporting a lot of complex tests in our hub center, and the reports are then dispersed to all our spoke centers. We have digital PET CT, advanced nuclear medicine therapies. There are a lot of patients who are not responding to radiation therapy, chemo drugs, gene therapy, who cannot afford gene therapy, and then we have a lot of advanced nuclear medicine therapies that we use on those patients, and we have seen excellent results through these radioactive isotope therapies. Just like digital pathology, we also do teleradiology, we do telenuclear physics for radiation therapy. So these are essentially highly specialized niche services by experts that we have sitting in our hub center, and all the reports through radiology imaging systems are pushed here, and the experts sitting here, again, using a multidisciplinary approach, using deliberation consultation from all niche experts in the hub center, are able to report from one place. And this really helps us give economies of scale, cost-effective treatment to our patients, and give access in all parts of the country. Now we are seeing AI-powered radiology information systems, radiology imaging systems, really AI being used in a lot of digital radiology, digital pathology, that's empowering our radiologists, our diagnostic physicians in precision in diagnostics to that extent. Similarly, in treatment, I mentioned previously, we have high-end radiotherapy techniques for precise radiation treatments. We have CyberKnife, we have tomotherapy. There's very few centers. It's interesting, in India, there's only 6 CyberKnife machines in all across the country, and with a huge disease burden, prevalent and exponentially increasing every year. We also are looking at radionomics and growing immunorad treatments. That's something we are focusing on, again, from radiotherapy perspective. I spoke about gene therapy and high-end nuclear medicine radiation therapies. We also do a lot of robotic oncosurgeries. I think we are the largest operator in India, doing more than 40 radio oncosurgeries every month. That's about close to 500 surgeries in a year. These are only oncosurgeries where we use intuitive robots, where a clinician sit on console. Again, it's precise treatment. with that much improved outcomes for the patients. The patients have lower length of stay, lower blood loss, and improved clinical outcomes. We're also doing advanced stem cell research for treatment, for recovery of these patients. This is new in India. We're one of the centers that is investing a lot in this area, that's really looking at it as a stepping stone to the next level of precise treatment that will be available for cancer patients. We are also doing hyperbaric oxygen therapies that helps in healing and recovery of especially of radiation patients. And we focus on holistic rehabilitation services, not just like I mentioned, not just on adding years, but also adding quality to the years of life that we've added to our patients' lives. And therefore comprehensive holistic rehabilitation services where we look at speech and swallow of the patient, gait, physiotherapy, nutrition, diet, psychological therapy. So all of that rolled into a very comprehensive, robust program that we offer to most of our patients, definitely to all post-radiation and surgical patients. I would also like to talk a little bit about digitization to drive these synergies. And it is so important, especially in a country like India, which is marked with, a lot of geographical divides, a lot of language regional divides, a very large country with a very large, we're the most populous country in the world now across China. And therefore, digitization is a solution. What we don't have anymore in our country is a digital divide, because we see that in our rural areas, in tier 2 3 cities, there's more higher penetration and higher prevalence of internet services, of smartphones, of connectivity. It's all improved. Our government has invested a lot in building infrastructure for it, and therefore digitization really is the way by which we can increase access, increase reach, increase availability in all parts of the country. And this is something we are focusing on for cancer treatment. We have a large footprint of 23 centers across our country. We have 23 hospitals, and like I said, we use a hub and spoke model, where a hub really is our main hospital, which is a center of excellence, which has some of the best specialists of the country, and it is in Bangalore in South India. And then we have all the other network of 22 hospitals that act as spokes, and we draw synergies through teleradiology, telepathology, teleconsultations with our experts sitting in our center of excellence in Bangalore, telephysics, to be able to give this access and availability of niche, high-end, gene-specific, organ-specific care diagnosis, care planning, and treatment protocols to patients all across the country. We also run virtual tumor booths, where specialists, again, from all across the country come together, and through all the disciplines and subspecialties, and this is virtually done, connecting complicated cases and specialists involved in complicated cases across all our 23 centers in the country. We have partnered with Microsoft. I talked a little bit about virtual reality. We are the first and probably the only healthcare partner so far of Microsoft to be using HoloLens for proctoring surgeries from our hub center, surgeries happening in any of our spoke centers. We're also using it for doing virtual tumor boards, and also for academics, for research purposes, and also for education and our fellowship programs in guiding our students and fellows from our hub center. Aside from this, the real advantage of digitization lies in reducing the cost burden both on the hospital, for our spoke hospitals, which are in smaller towns in tier 2 3 cities, where there is paucity of clinical talents, not possible to hire good clinicians, good technologists, good radiologists. It solves the problem of availability of resources, as well as it solves the problem of cost burden, and therefore the cost being passed to the patient, and hence overall reduces the cost of treatment for the patient. And we also see that it helps us maintain quality of care. There is great homogeneity in the way we deliver care. Our protocols are consistent. As a result, our accuracy and precision is intact, and the quality of services delivered in any of our centers is therefore homogeneous and alike, and is of the standard that we want.
the National Heart Institute in Kuala Lumpur, and I'd like to say it's an honor for me to share some experiences in regards to NCD management in our hospital at the National Heart Institute. Uh, my brief today is the important role of specialty centers in managing NCDs in clinical practice. And I'd like to look at it as redefining risk management. And I think this is a very important part of the work that we do because many of our patients are getting younger and non-communicable disease is very common in Malaysia. So once again, thank you, HMA, for having me. And I have no disclosures to make, as you know, a bit about our National Heart Institute. We are the probably arguably the largest tertiary cardiac center in Malaysia. We've got about 461 beds, and we offer pulmonary as well as cardiac, as well as vascular types of surgery. So a little bit about what we do, and I think it's a no-brainer because the role of specialty centers, at least in my mind, is principally to control, manage, and reduce risk for primary prevention as well as secondary prevention in regards to cardiovascular disease. And I think these are the main risk factors that we have to contend with: obesity, diabetes, hypertension, and dyslipidemia. There are many others like smoking and so on. But be that as it may, these are the main ones. So I like to divide my brief lecture into several parts. Part one is a recognition of a problem in Malaysia. This is a major issue because prevalence of cardiovascular disease risk factors is high. Many of our general public are actually obese, and of course they have hypertension at 42%. These are the latest National Cardiovascular NCVD surveys, and hypercholesteremia accounts for about a third of our patients, of our people in the general population. And that's a very high percentage. And again, at least 80% of our population actually have one modifiable cardiovascular risk. Now, when we look further at how this unfortunate contributions culminate in atherosclerotic cardiovascular disease, the mean age for our patients having ASCVD or HCS, they are about 58 years. And this is about 5 to 7 years younger than most patients in other parts of the world, as per the REACH registry, which is a large global registry. So our patients are younger, and we have patients as young as 21 years old with atherosclerotic cardiovascular disease, or even acute myocardial infarction, and even triple vessel disease at 20 plus years old. This is incredible. So again, our data shows that patients in IGN with ASCVD, many of them are diabetic more than 50%, and many of them do not reach, less than a quarter actually reach target guidelines as recommended by the ESC at 1.4 for very high risk individuals. Now, having said that, the ACCHA recommends several modalities in terms of assessment risk. These are cardiovascular imaging, lipid analysis, and subsequently the risk estimation. This is important. The last two are important because they are the mainstay of risk management. And of course, in the National Heart Institute, this is a very important issue. But be that as it may, globally, the attainment of LDL is still very low. These are patients who are very high risk and high risk, and attainment of target LDL levels at 1.8. It's only 39%. If you go to the lower guidelines suggestion of 1.4 millimoles, it's only down to 18%. These are European populations. And of course, in Malaysia, this is even higher in terms of non-attainment of goals. If you look at Malaysia, our latest data shows that although we are in an enviable position of 80% of our patients actually getting medications, only 37% still 37% do not achieve the levels that we want to target. And these are nowhere near the higher, more aggressive targets that's recommended by the guidelines. So you can appreciate the magnitude of the problem in terms of its impact in atherosclerotic cardiovascular disease, productivity, youth, and of course, these patients who have coronary artery disease who survive are lifelong patients indeed, yeah? And some of them are heart failure patients. More worrying is the fact that in secondary prevention, only 25% of patients are actually on lipid-lowering therapies. Now, I think you can appreciate the sort of problems that we have. We have got a gap. We've got patients who, for various reasons, are not on medications, and even lesser, who have poor control even when they are on medication. So I think we are faced at the National Heart Institute with several clinical challenges for NCD, non-communicable diseases. We have an increased complexity of therapies, of course, many injectables, orals, and various types of them. More aggressive therapeutic goals because of the guidelines being evolved, and for younger patients in our countries and indeed in Asia Pacific as well as South Asia. There's shorter doctor-patient consultation time because many of us run very busy clinics. Physician unfamiliarity is quite surprising because many doctors may not be familiar with newer target, especially in the very high risk groups. And this doesn't apply to just cholesterol, it also blood pressure, to sugar levels, and so on. And of course, increasing patient expectation. This is to be expected because of the digital platforms nowadays, accessibility of information, and so on. But also, unfortunately, there is also digital disinformation. All these impacts on adherence, and patients can have issues in regards to taking medication. So we need to bridge that gap. So what do we do? I think we have at the National Heart Institute gone to the next phase of our strategy, which is the part two, where I'm talking about a physician-driven approach, and this is the cardiovascular risk reduction clinic, or we call it a CRRC in IGN. And this is to establish a multidisciplinary approach towards reducing risk. In this particular case, lipid, but it applies to other risk factor management as well. Of course, ultimately, it helps to improve life expectancy, and it's got defined targets inclusive of therapeutic lifestyle management. And I think we want to improve adherence to medication by about 50%. These are humble goals, but I think it will go a long way towards reducing risk. And of course, from time to time, we would have an audit. So I like to illustrate what we've done so far, insofar as the CRRC and lipid clinics are concerned. And I think the idea is actually to share best practices. I know best practice itself can be kind of restrictive, but I've added a caveat there, which is we should temper it with continuous innovation, which is what we've done. And I think in regards to this, we have three areas that we've concentrated on in IGN. This is the private-public partnership you see on the right here. And I think this involves the industry itself, which are often multinational corporations. And then we have a comprehensive treatment offering, which includes the CRRC, which involves multidisciplinary individuals from different disciplines. And of course, ultimately to transform into a center of excellence. So these are the three main thrusts, and of course, it is a part of the ecosystem of IGN itself in terms of offering good service, best practice to our patients. So I think on the route to building IGN as a center of excellence for cardiovascular risk reduction, with, as I mentioned, the cardiovascular risk reduction clinic, CRRC. It is a multidisciplinary approach. We have management protocols which we have evolved with industrials, of course, with our peers and international partners. And of course, subsequently, to move on to research collaboration based on the data that we have acquired, or we're able to harvest from our patient population, and subsequently develop ourselves in Center of Excellence in atherosclerotic cardiovascular disease. So these three, if you like, pillars of management or approach in terms of trying to address this NCVD, perhaps unique to our setup at least. We don't know any setup that has actually incorporated this together with the various partners, including industry, trying to achieve the reduction of secondary prevention and primary prevention indeed of risk factors in any hospital setup. So I think the first step is to get the physicians to buy in, and this involves our fellow physicians and cardiologists to have them appreciate that there is a problem with regards to the gap of the therapeutic gap. And of course, involving, of course, next stage, the hospital management. That's the next level, because with them, you are able to get more things done, get manpower, resources allocated, and so on and so forth, as well as finances. Of course, the allied support, the nursing, and of course, the industry are important. Most of all, the patients have to be agreeable and are keen to participate in the program. It's not so difficult because when you consider the unmet need of lipid management in Malaysia, that those in the high risk group, 50%, only are in achieving LDL level cholesterol. And this is probably an optimistic percentage, as you've seen earlier. It's most likely lower than this, but this particular figure shows that it's a 50%. For those in the higher group, what's important is that the lower group has a higher cholesterol, lipid-lowering medical therapy uptake, but the higher risk has got less. So I think many of our colleagues actually appreciate this. So when you plan a service, the most important step, I think, and personally I feel that one has to do is to identify a champion who is passionate about this and willing to pursue and willing to convince others that this is an important step. And of course, expand upon existing resources, rescaling our staff. We have staff, we have got diabetic educators, the DEs, and recruitment of staff as necessary. But most importantly is to unsilo our services. I think most of the risk management centers in many hospitals, in fact, even overseas where we've been, we know that they are managed differently. The hypertension clinics are hypertension clinics, the diabetic clinics are diabetic, and so on. Lipid clinics may or may not be existent. Some are classified as familial hypercholesterolemia clinics. But now again, we know that familial hypercholesterolemia itself is not very many. Very often the genetic studies come back negative, and this is because of polygenic causes of the dyslipidemia. And so again, the idea of familial hypercholesterolemia clinic, which we started initially some years back, has evolved. And so again, the idea is we have unsiloed ourselves and developed sort of a spoke and hub sort of ecosystem to concentrate on our cardiovascular patients, and in particular trying to reduce their risk. So as you can see here, it involves cardiologists, endocrinologists, allied health. We have all this, as in many hospitals, this expertise. But most importantly, we have actually actively engaged the industry. Now, I'll show you in a minute how the industry actually plays in onto this general scheme of things. But I think over the years, we have learned to utilize our limited resources, and we have been using the Diabetic Educators Clinic for some time, which started way back in 2004. This was a specialized clinic for addressing diabetes in a tertiary cardiac center, which is not an endocrine center. And this is 18 years ago. So at that time, the idea of having a diabetic clinic cardiac center was quite unusual. In any event, we had our specific cardiac clinic. We have specific nurses trained and exposed to various centers regionally as well as through training. And subsequently, this has actually evolved over the years. They have done more and more things. So the diabetic has evolved to diabetic lifestyle clinic. Mind you, the staff has actually been trained and more people have been recruited. And it now evolves into obesity management back in 2020. Now, we include that as well as for cardiovascular risk. But then recently, we've also included it as a lipid management. And again, this is somewhat different because for lipid management, we have also incorporated industry in developing this service. There are benefits in engaging with the industry because we have now available new therapies which the industry is able to bring in, and these are rather expensive medical treatments. They may be injectables, they may be devices, and so on and so forth. It also affords research opportunities. They have resource in terms of funding for developing materials, education materials, digital materials, and so on. There is an international networking opportunity in terms of interacting with key opinion leaders. They know who's doing what and how it's done and so on. So we don't need to reinvent the wheel. And of course, they can organize CME to try and disseminate information about guidelines and so on and so forth. So the potential is huge given the fact that the industry itself are now multinational corporations. Most importantly is, of course, there are new therapies in all these major risk factors. Obesity has got the GLPs, receptor agonists, and of course, they have got multidisciplinary cooperation with the surgeons. The hypertension risk factor has got ambulatory blood pressure monitoring. We now have renal denervation, which is now recommended and has evolved to a better, more effective method of controlling blood pressure. Diabetes with continuous glucose monitoring, non-insulin injectables, and of course, we've got the GLP-1 and the SGLT2, newer therapies, not new, but newer therapies. They've been around for some years. And of course, dyslipidemia, we have non-injectable, this PCSK9, and of course, your alirocumab. So what have we achieved over the last year and a half or so since we started and mooted the idea of this partnership and this model? We've teamed up with Novartis, and this is our announcement. We've got MOU since last year, and that's finally culminated in the formal agreement. And in our news portal, it's got 4.35 million readership views, and these are examples of a CEO and representative from the industry. And I think this is probably quite an innovative development in our service. So I think for the clinic itself, this is the patient flow. It involves outpatients from the inpatients as well as outpatients. And we have referral systems, and subsequently they have visit 1 and visit 2 for optimization and visit 2 for stabilization. Down at the bottom, you see nurses, pharmacists, dietitians, and so on involved. So many people are involved. These are the inclusion criteria. In the interest of time, I won't go into detail, but these are the criteria, which as a rough guide for the admission. But the admission admission to this clinic can be any patients for that matter, not just necessary. These are just guidelines. And of course, what's important is to get buy-in from the patient as well as from the physician, this idea of risk scoring. And we have two things here, 10-year risk score as well as a lifetime. This is very important because patients need to know they may be at low risk now, but in 10 years' time, they may be high risk. Or for that matter, they may be at low risk at 10 years, but a lifetime risk may be very high. So depending on what their age is, the level of cholesterol, and so on and so forth. It gives them a visual idea, and you can see over the x-axis at the bottom of this booklet, you can see the year and the risk as it goes up or goes down. So it gives a visual buy-in for the patient and for the physician as well as to where he's headed in terms of risk management. So this is a very important development for me at least and for the team to include in the management of the lipid clinic. It's not so difficult to buy into the idea because we know that post-MI patients, 10% have an event after the 1 year and 20% even after the 2 years. So there is a real risk of getting a second myocardial infection or in fact acute coronary syndrome. These are the overview of roles and responsibilities. You can see various peoples involved, nurses, clinicians, so on and so forth, an idea of what they are supposed to do. And of course, we have an assessment form for compliance, which is very important. So finally, there's no point in doing something without tracking the success. And we have patient outcomes, as service outcomes, and I think this is very important. We have put in place things to actually measure how effective we are. And finally, when we look at what we have for the future, and I think in the horizon, what we're going to have is actually to apply this. We have already applied it for hypertension, where we're going to apply it, and also for diabetes, but to a lesser extent. But obesity also will have the same developments, hypertension, diabetes, with various industry. For example, diabetes will probably be with Novo Nordisk, who are very active in the programs for diabetic patients. And for hypertension, we have Medtronic for renal denervation. It's all in the pipeline, and we've had discussions. Obesity, of course, involves the Saxenda or weight reduction injections, GLP-1 RA. So this is an example of a obesity patient, obesity clinic, an inpatient who has reduced, was reduced his blood weight from 123 kilogram to 119 within about a month, and thereby obtain dramatic improvement. But this involved various people, nutritionists, our obesity clinic nurses, and so on and so forth. Patients are now, the patient himself is much better, more confident, more motivated, and so on. This is an example of our diabetic clinic. Again, HbA1c was difficult to control, but we're using the new formulation, the longer formulation, Rhizodec, which has managed to control the blood pressure quite well after several consultations. And our nurses actually go for phone follow-up every 2 days for insulin titration, which takes load from our doctors. I think the messages to take on my last 2 slides is to look at your problem in your particular setup. And ours is, as mentioned earlier on, to identify the problem, identify objectives, identify the approach to a solution, which may be unique to your setup, and identify a champion. To me, that is the most important thing. I think it has to be physician-driven, not for anything else, but because I think they're able to interact various disciplines relatively effectively. But anyone will do, I suppose, and identify your resources, manpower in terms of, and of course, cost, identify the partners, industry or otherwise, and of course, good luck to your plans. I'd like to express our sincere, the CRC would like to express a sincere appreciation to IGN management for their trust in us, the nurses, allied health physicians, cardiologists of the department in particular, who's been instrumental, the Iskandar, another team member, the Nurse Chong team, of course, our industry partners. Finally, these are the team. It's a lean team, but we have a lot of other people which cannot be included in the photograph for physical reasons. But we, again, for me personally, I'd like to thank all of them. And once again, thanks to HMA for giving me this opportunity to share this on behalf of the CRRC to show what work we are doing in IGN. Thank you very much.
Right. Thank you.
Good afternoon, everyone. Thank you for coming to our discussion. I know it's been half virtual and half here on site, but we appreciate you attending and hope that this will be a little bit more interactive now that we're not on video. I wanted to spend about the next 20 minutes or so talking about the importance of specialty care centers and optimally managing cancer patients, both within the context of non-communicable diseases and also the transgression to and from communicable diseases as well. So first, before I do that, I always like to start with just a little bit of introduction. That way you can tell and understand the point of view I come from. And I always tell people right off, I am not a doctor. I might play one on TV, but I am absolutely not a doctor. I've spent my career over the last 2+ decades working in academic cancer centers, both in the United States at MD Anderson for approximately 20 years, setting up their cancer network all around the world, both clinically and academically. In 2016, I had the opportunity to take all that knowledge and to really look at how we could enable physicians and care teams to do more and to do better by technology, focusing on big data, focusing on analytics, pharma, and really the digitization of healthcare. Since that time, I've had the opportunity to join Varian and now Siemens Healthineers to continue that journey and to really look at how can we use digital technology and clinical services to bridge the gap on a global basis in order to provide high quality, high efficient, and overall best outcomes for every patient. So I wanted to start with newly diagnosed cancer in Asia, and none of this is new to any of you. There's expected to be almost a 50% increase in new cancer incidence by 2040. We all know that. What most people don't realize is that approximately 2/3 of those cases are in the Asia-Pacific region. What's interesting is that this, I think, is a multiplier effect of communicable diseases that cause cancer, coupled with non-communicable diseases that cause cancer. Typically, in lower income parts of the world, you see higher rates of communicable diseases. These cause cancers such as cervical, such as stomach, liver, and these are infections, these are bacteria, these are parasites. What most people don't realize is that about 70% of all communicable cancers caused by communicable diseases can be prevented, if not eliminated, by vaccines. In low-income countries, this is not happening yet, but in middle-income countries, you're starting to see vaccination programs. You're seeing much more health commitment of governments in order to really look at vaccination. At the same time, you see in those countries that are more evolved, non-communicable disease that is causing cancers, such as lung being an excellent one for tobacco, breast, prostate, colorectal, all very highly correlated with obesity and with diet. And these are multiplying. And so when you look at the Asia-Pacific Rim, what you see is 65% of the countries actually are in the mid-economic tier, which means they haven't bridged the gap from communicable diseases and those cancers associated to high or non-communicable disease cancers. So in fact, it's multiplying because we know that vaccines take 20 to 30 years to actually show reductions in incidence. So in this region of the world, by 2040, we're going to be looking at 2/3 of the world's cancer patients right here. At the same time, you're looking at a part of the world where screening and prevention is often not as embraced. Quite honestly, that's a global problem. We all have it in different forms, in different ways. But what we do see here is a large percentage, 70 being the percentage in lung cancer, of patients who are diagnosed at a very late stage. And as we all know, late stage, unfortunately, tends to equate with not a lot of options that are actionable and, unfortunately, bad, poor outcomes. You also see the cost of care skyrocketing. 48% of the Asia-Pacific market actually states that they had financial personal catastrophe after trying to pay for their care, which is not sustainable either. And we have a provider problem. In many countries we're seeing this around the world, but in this geographic, you're seeing that a typical oncologist sees on average 300 to 500 patients per oncologist. Typical US, typical UK is typically 150 or 200 per oncologist. So we need more people, we need earlier interaction, and we need better diagnostics. So on the other hand, you're also seeing a large change in the market and the services. We know that services are shifting to outpatient. There's been a 5% increase, and it's projected out, for growth on your outpatient side of the house. You see things like cell therapy taking off, mammo, colonoscopy, other screening devices are really increasing on the outpatient setting. Conversely, on the inpatient setting, the whole game now is how do we keep people out of the inpatient? How do we reduce average length of stay? How do we reduce complex surgeries that lead to negative or high-end complications? So we're seeing a decrease on the inpatient and an increase on the outpatient, coupled with continued rise in drug cost and device cost. And I think that's predictive of technology and of pharma. We're not surprised by the drug cost. You know, over the next, to 2026, 5 years is 39% increase. We've been experiencing that year after year. The interesting thing is that on the device market, we're expecting more than 100% increase due to just the acceleration of technology. As we heard this morning, and I think Doran is in the room back there, digital transformation and what we're able to do with technology has far expanded past most people's even dreams. So we're seeing that translate into devices and into appropriate associated cost. So this is where I stop for a moment and I say that while I personally believe in specialty care, I absolutely don't believe that's the only answer. Cancer care is a team sport. It takes a village, if you will. You know, and some of the interesting stats, I think, are that within less than 3 months of a patient being diagnosed with cancer, his or her primary provider interacts with that patient more than 11 times in less than 3 months. At the same time, that provider is interacting to coordinate that patient's care, often in a very fragmented system, more than 52 calls for that one patient. So if you think about it, if an average primary doc has a panel of 200 patients, that's 10,000 calls a year they're making just to coordinate care. We got to do better than that. So kind of walking through the continuum of cancer care, starting with screening prevention all the way to survivorship, here are some of the problems that, you know, our community, our primary, our internal medicine, you know, care teams are seeing. They've got cancer alarm system. They know that there's a persistent cough, which could be cancer, it might not be. They can explain weight gain or weight loss or bleeding. And so all of these factors are alarm signals for cancer, but not necessarily cancer. It could be indicative of poor lifestyle choices. It could be indicative of bad diet. But these are the type of things that that provider has to ingest in order to try to make a diagnosis. But what it really takes to make that definitive diagnosis is specialized technology and comprehensive lab panels, molecular analytics. It takes high-end, expensive services to make definitive diagnoses. And so what this says to me on the prevention and screening side is there couldn't be an area where coordination is more important. Most community providers can't afford or don't have access to on-the-spot molecular analytics or high-end technology. They have to work with specialty centers for appropriate diagnostics. And this is always my favorite one, the actual diagnosis of that cancer patient. It's been stated in multiple reports that, you know, typically speaking, about 12% of pathology in cancer is wrong. It's wrong by stage or it's wrong by disease. Now, I will tell you from my history at MD Anderson, we used to track this. And at some, you know, high-end cancer centers, that number is more like 30. It is staggering. That's why I always tell people, get a second opinion. And you know what that means for Asia Pacific is by 2040, that's 1.8 billion people who could be misdiagnosed. And we all know if you're misdiagnosed, we're starting from the wrong position. We can't even hope to give you the best outcomes as a patient. Molecular diagnostics has also become a gold standard in precision medicine. We, are seeing that to become part of workup, as it should be. But And this is of no fault except just the acceleration of knowledge. 72% of oncologists report informal or no training in interpreting those results. Not surprising. The whole field is moving at warp speed. And another 86% of oncologists report they don't really know how to interpret the results or the risk. So what happens? They don't order it when it's clinically indicated, or they order it and they really don't know how to benefit from it. Again, we got to do better than that. In treatment itself, and this is another one of my favorite factoids, which I'll put a plug in. If you get the next compendium, the article that I co-wrote with my colleague has all of this data in it. This is the importance of really knowledge and clinical decision support. No care provider today can possibly understand everything that is out there in real time. It is not physically possible for a human. And you know, in 1950, we thought that that knowledge would double every 50 years. In 1980, 7 years. In 2010, we thought 3.5 years it would double. But today, the frightening fact is that every 72 days, as a physician, what you think you know is only half of what's out there. That's frightening. 72 days. I can't even stay on a diet for 72 days. It's really an amazing point. And what that means is that we have to provide care teams clinical decision support in the form of pathways and guidelines, in the form of molecular analytics, in the form of real-time consultations and treatment discussions. All of these are essential in today's world of really being patient-centric. And last of all, quality of life and survivorship, and I kind of purposely call it that because I'm a big believer in value is quality over cost defined by the outcome of the patient. That may mean that the most important one is mortality. That may mean it's quality of life. That may mean it's financial. But it's understanding what is quality to that patient. And there couldn't be another area where that transition between specialty care and primary providers is more important. You know, 34% of all patients that are under some sort of palliative care are cancer patients. That's a tremendous amount. And we know that the majority of cancer patients have to deal with pain in some course of their disease. And it's also a disease that they live with for the rest of their life. This doesn't go away. It's not a bad hair day. It is something that has changed them, has changed their bodies, and will always change how they handle prevention and screening. So, where does this leave us? You know, I mean, the truth of the matter is that despite the significant advances in understanding of cancer and how we treat it, there is a wide global disparity in access. And to be quite honest, who benefits from all this technology, all this knowledge, all this learning? And we have to bridge that gap. And the way to bridge that, I strongly believe, is the utilization and really the digital transformation of oncology as we know it today. And this is one of my, and I will admit, I came up with this because it was the simplest way I could clearly show from a patient's perspective, how do you look at that patient across their continuum of care? How do you identify how to support that care team, whether it's through patient engagement tools, whether it's through technology, whether it's through clinical support? And then what does that digital transformation look like? In patient engagement, it might be symptom tracking, it might be triage of patients, it might be patient-reported outcomes. In technology, it might be virtual experts around the world that are helping you arm that machine and give that treatment. It might be remote treatment planning. It might be virtual training. And then from a clinical support perspective, you know, that is really the clinical decision support, whether it's molecular in nature, real-time second opinions, or even clinical trials matching. But we have to digitally connect and digitally enable our care providers on behalf of that patient, regardless of their location within the continuum of care. But even that's not enough. If we don't take that data, that digital transformation, and actually make it into knowledge on every single patient, we've wasted it. That information has to become knowledge. It's not just data. It's knowledge that we can use to create best possible outcomes, to change practices, to change physician behavior, and ultimately to really bend that cancer curve and start having better outcomes everywhere in the globe, regardless of where you are geographically. So as I summarize, just wanted to give a good example. And as I said, I've worked all around the world. There's very few places, from high-end academic centers to community centers to startups to centers of excellence. But there's a couple things that are constant. And a good example that I'd like to share is the American Oncology Institute in Hyderabad. It's a cancer program that we run and operate, so I will be biased in that. But it is a hub and spoke with 16 locations all across India with integrated lab and molecular diagnostics that has created a digital healthcare ecosystem. It's connected its sites with remote treatment planning. It's connected its site with tumor boards. It's connected its site with LIS systems. It's not 100%, but they are leveraging knowledge all across the country for the benefit of the patients. And the nice thing about that, when you go a little bit farther across the globe, Healthway Cancer Care Center is the first comprehensive dedicated cancer center in the Philippines. It's about 12 months out from opening, and they're already leveraging not only relationships from all around the world, but our team at AOI, and talking about what are
you even sometimes. So all of these are little elements that you can start teaching these doctors how to improve on. The other elements is also talking about them about what patients' expectations are around how long a consult should be. Okay, you do one for 5 minutes on a teleconsult. I promise you the patient will complain that it will be too short. So, but those things are doctors feel that they know best. But we all live in a digital age. Doctors want Zoom. We've seen third-party teleconferencing software that allows you to use it for your telehealth solution. We've used it. We are okay with what we have right now, I'll be honest, right now, but we see a room for improvement. And these are things like, as simplifying is allowing the user to test out their connection before they connect into the video call so that you can avoid any internet mistakes, poor connection issues, and making sure both sides are prepared. Making sure all of the elements the main interaction elements, and these things are mute, show video, share files is actually a very, very key function for teleconsult, because doctors will have, the patients might have scans from one doctor that they want to get a second opinion from. How do you upload these files to them? So that's all elements of it. So you're guiding that user as smoothly as possible through the journey. And of course, this is just a last point is, as I mentioned, we have older users quite a bit as our patients, as all of us get older, more and more health issues crop up. So how do you make sure that their family members are part of that conversation? How are you including them? And these things are hard to prescribe in a directed manner, but you basically make it options. And these are, you start all the way from the booking journey, which is, do you want to include anyone else? Do you want to include a family member inside the call? And then you start, and if you need to, will they be joining in separately and giving them a link for them to join in through that? So these are like, I'm doing things in like generally 3 except for my last slide, which is going to be about 2, because I think it's easier to remember. But there are a lot more sub-details that will go into this that will inform your patient journey and trying to think about how do you close that gap in building the human touch. Last one is maintaining connection. As I mentioned earlier, a lot of times patients don't feel satisfied from just a single teleconsult. How do you actually maintain that connection with them, right? And that goes back to two parts. One is from the healthcare provider's perspective, you follow up with them, and that's as simple as doing a customer satisfaction scoring or NPS. But it can also offer, you can do this in a more detailed manner, which is giving them a nursing number or clinic number for them to message you, or they can send you interfaces through the patient portal. Send questions through the patient portal to help you address any worries that they have. And these things does not necessarily need to be manned by the doctor initially. This can be the clinic assistant, this can be the nurse that you have assigned to this duty, and they can follow up with the doctor if there are things that's beyond their ability to answer. But a lot of times it's going to be very simple questions like, how often do I take this medication? Is there an order that I need to take it? Do I need to not eat? Yes, it's all on the prescription slip, but they don't read that, right? But it is these small touches that you would have done physically in the clinic that they would have asked that is missing in the digital side. And all of these are elements that you want to start thinking about when we talk about maintaining the human touch in the telehealth communications. And I'm almost at the end of my last slide, which is just a part a little bit piffy, but we talk about it as telehealth, but maybe it's something that we can consider just calling it telehealth care, because that is why we are all in this, right? To talk about caring for our patients, provide them the results, the outcomes that they are looking for. And yeah, it's often forgotten that care is what you need to address as part of your solution. And that's it for me. Thank you very much.
Thank you very much, Dylan. Actually, please don't go just yet. I'd like to invite you up on stage for our panel discussion. So alongside with Dylan, I'd also like to invite Dr. Arthur and Dr. Surankana on stage as well for the panel discussion. So along with our panelists, we also have the moderator for this session, Irene Kwan, the CEO of Malaysia's TMC Fertility and Women's Specialist Center. Welcome, Irene. And now I'll leave it to our moderator to kick off our panel discussion. Let's give them a warm round of applause.
Thank you, Natalie. Thank you very much for the warm welcome, and also to our brilliant three speakers who have actually shared so much insights with us. Now, shall we open up the floor? Yeah. Are there any questions from the floor? Looks like the hall is full today. All right. If you do have any questions, please scan through and put it in the Slido. We'll be more than happy actually to address it. Now, while you are entering your questions, I do have one question for our speakers. You must agree with me, they have been really doing a very good job in sharing their insights with us. Telehealth care journey, indeed, is not new, but yet is definitely not something easy to implement. How many of you here from organizations where you already have telehealth care in your organization? None? Thank you. Well, it looks like a lot of hands are not up. Or is it because no matter whatever questions I ask, you will not raise your hands, is it? I understand that it's after lunch. We have been given a very heavy responsibility, but please bear with us. The topics today is really hard. Now, I do have one question. Now, other than the few hands that have raised earlier on, that you have started the telehealth services in your organization. Now, how about organizations, right, who have not started it yet? So how do you actually embark on it? How do you start it? Where to start? Let's not talk about how to start first. Where should we start? Any speakers would like to take this up?
I'll take this question. So I think it's one of those things where I doubt there's anybody here who has not had to roll out telehealth solutions, but for some random reason it's not been done. Um, I think it's really identifying first like the use case. What exactly do you want to offer? Is it really a GP based basic health consultation, or is this a question about um, you want to push this across all your specialists, right? All of your cardiology, oncology, orthopedics, etc. If you're looking at getting that started, I would start with the physicians, the doctors that you're working with, and identify the doctors that you feel would be strongest piloting this, and start with their specialty first, and push that out, because trying to get 100 doctors to all agree to the same thing uh, and agree on the same process is much harder than saying these 3 doctors are pro for it, they want it. Let's work out with them a process that we can then use as learnings to apply to the larger organization. Um, yeah, and that would be my approach. Basically, start small, start narrow, and take those as learnings before you start trying to scale this up and say all our doctors have to be on it.
Yes, indeed. Thanks, Dylan, for that.
So actually, for me, I would say it's about how you position your organization on telemedicine. I mean, a lot of people think at first when we start using telemedicine, doctors thinking that we are stealing their job to see patients instead, and then put them in through the box to talk to something, and then sometimes the perceptions of the doctors and nurse who work, and as Dylan said, we need to talk to somebody that understand really of what we are going to do. So when we start the telehealth, it's the value that we would like to give to patients and the benefits of the doctors that will get after it, after using it, and stay on top of it. Is the key things that we need to think in mind and put the strategies on that, so that we can, frankly to say, easy as that, you have to sell both patients and doctors. So if you can sell the doctors, if you can sell that to the doctors, then I think to sell to patient is not that hard for us to do.
That's true. That's true.
For me, I think my experience at some state groups, we start with a general simple disease first, because we think that in another country, like in China, in US, we have the telehealth is is a must. So we start with the general, and we ask the doctors who would like to engage in this care. When we start, I think when we start with a narrow or specific area, for some doctors, there's only few doctors that would like to engage in this program. It works, but when you would like to expand, it's very difficult. After that, patients would like to talk to their specific doctor in some specific area. It's very difficult to engage doctors in subspecialty to use the telehealth. Like in my children's hospitals, for the general pediatricians, it's okay, but for some specialties, they refuse. But we find one area, like in child development, because of COVID as well. But at that area, it's the team, not only the physician, not only the doctors, the team, they engage. I think like Dr. Arthur says, we would engage both patients and doctors and find area that doctors will see the benefit of this program and start and expand little by little, and then you can, I think, achieve all the outcome of this program.
That's true. It looks like in order to really implement this successfully, you really have to zoom in to targeted crowd first. Start narrow, start niche, start very focused, and provide the kind of support. I'm sure you agree with me. Changing the mindset of the doctors is really not something easy to do, right? So I think personally in my organization's experience, now I actually run fertility centers, so I only work with O&G doctors. It's only one discipline. So I have no other choices. So before the pandemic, we have been looking into telehealth as well, convincing our doctors to take it up when there is no need, really tough. So when the pandemic comes, it becomes the new norm. The doctors themselves also in fear of getting COVID infected, they also want to pick it up. But not all of them are savvy with technology. Some of them, if you notice, right, they may not even want to change their mobile phones, you know. Do you still have doctors in your team that still don't use smartphones? I see the heads are nodding. Yes, yes. So precisely, if you understand that point, you know, it's very important, you know, from the messages like our speakers have shared, is to provide that support for the doctors. Maybe start with smartphone first. Getting them accustomed to technology, gearing them towards the kind of mindset. And it does take a lot of patience here. So for the past 3 years, at least, you know, we have seen some fruit of success as well. So is there any other questions from the crowd? Ah, yes, it looks like
on the Slido.
about to come in. No, okay, I can't see on my iPad. All right. So what is the general age demographic of patients that adopt telehealth?
For me, that's also wide range. That starts from young children to elderly. And that's because of the generations that use, especially the elderly, as you say, they are not tech savvy. Of course, we are the one, I mean, our generation were the one who set up the password, and that must be something very easy for them. So with the support of the family, they perform the telehealth. And also we have the sectors or the sections inside or nearby to support. Means we call to connect with them. At first it was easy as we used Line or something to talk, but afterwards we use our own platform. It was challenging, but at the end of the day, with the full support of our team, we can do that. So the range is from, you per se, 5 up to, 5 up to 80 we can use in our hospital right now.
Right now, like for the submitted group, this is they use in like every age. Like for the children, the parents, because parents for the small children right now is a Y generation. They use to the technology, and for the adult, I think as they use. It's not like depend on the age, but depend on. I come back again for the doctors. If the doctors that take care of the patients, they would like to use this, they can, all age can use this telehealth. And for the old age, the family, children and old age, they need a family member to assist them.
How about Dylan? Is it the same in Singapore?
Yeah, I mean, in general, you can look at it as one simple thing. It is for the elderly or for the young, who is the primary caregiver. And usually that person is the digitally savvy enough one. The parent or the mother, the father will say, I need to see my doctor, how can I do this? And then the dutiful son will go and check online, hey, can do telehealth. Let me help you set this up, set up appointments for you. You can speak to the doctor this way. So there is no general age demographic of the patient. But what you need to do is understand that it's not just only your patient engaging with you through this, but it's also who's the caregiver and how do you include them into that process.
Okay, it looks like the good news is there's no age limit, not at all. So if any patient or doctor use that as an excuse, you know from this afternoon, no such thing. Okay? Now, next question. If there is no COVID-19 outbreak, how do you think telemedicine will be used? Is it different from the present? I totally agree. If there's no need, there is no fear, you can't create the demand. We have experienced that in TMC fertility as well. Imagine my O&G doctors, when I wanted to actually launch telemedicine. So they asked me, how do you do ultrasound on a patient via telehealth?
True.
I couldn't answer that. So I just dropped the topic for a while. And then, thanks to COVID. So when COVID came, my doctors were the one asking now, because they are in fear. They say, oh, first-time patient, don't want to see them yet. Telemedicine first, then only we bring them in. So the whole idea is to cut short the visits, so to reduce their exposure as well. So how about in Thailand for Dr. Surangkana? How's your experience then? Do you think if without COVID it would be different?
Like I think Bumrungrad start from 2018 and Smitwet from 2019. The number of user increase, but some only small like a curve in small number that increase. I think that in the future telemedicine, even though the COVID, the increased usage, but in some area, I think about the like a mental, in some area that there is shortage of the physicians and need like for like subspecialties. I think about the mental health, like in US, that is in the number of the patients that for the mental health use this, and like and it's different from this. COVID is the one that help us for implement the telehealth.
I would say COVID is the very good stimulant or catalyst. They accelerate the technologies. For us, if we don't have the COVID-19 outbreak, I think it will go into the terms of mental health care or physiotherapy or some chronic disease, which actually it will not go through, it will not come to the traditional Chinese medicine. I mean, there were parts of it. We were trying to find out how to pause, and it's very difficult, as you said. We heard from our friends in Singapore at the last two HMA about how they're using the TCM as the telemedicine, and it's very difficult for the Chinese pharmacist to arrange without pausing palpations. So without the COVID outbreak, I think telemedicine would be optional. But right now, because of the COVID outbreak, it has been the first front line to build trust, as Dylan said. If you haven't met doctor, try telemedicine. Because when you see the doctor and the reactions of the doctor to talk to you, you may be affected by him. So that's quite attractive. Doctors would be one of the channel to open the gate of your hospital through telemedicine.
Yeah, so that's a good point, Dr. Chachai. I think the other part is also after the treatment, after the procedure, especially for patients who live overseas and they don't want to travel all the time for follow-ups. It's a question of basically the doctor is just going to ask you, how are you doing? Is the wound healing fine, and so on? And there's no reason for that to require a physical consult. So if there was no COVID to expedite this, yes, it would probably be slower. As somebody I was discussing with yesterday said, COVID essentially forced 5 to 7 years of medtech advancement into 2 years. The other portion is you would have less common use cases. Your use cases would be really looking at the pre-visit, that initial get-to-know-you stage, as well as the step-down follow-up stages.
Thank you. And this is one of the positive part of COVID. This is one part that we should not be complaining. All right. So thank you. Now we have another question. What kind of patients who are not suitable for telehealth?
Emergencies. So that's the answer. If something acute care, please call ambulance instead of telemedicine. But the thing is that we lucky to have our applications. For example, in Bumrungrad, if you have the telemedicine on demand, it directs to the emergency doctor. So emergency doctor will triage right away, and then there's also the small button that you can press and call the ambulance right away. So that's how we put through, and I think Cemeteries also has.
Yeah, the same.
Yeah,
Yeah.
same one.
I mean, it's really, it's not a patient. It's actually an illness issue that is decides whether you're suitable for it. As mentioned, emergency.
Yeah, true.
It's something as simple as knowing that you kind of have a fractured toe or whatever it is. You can't really solve that through a video screen.
So it looks like if there's any bleeding and really in a lot of pain, don't bother using telehealth, go straight to the emergency department. But it's good to know that when you actually develop and build your telehealth, this is one function that you can actually look at as well, where proper triaging, you also have to have easy access to emergency care as well, not going through big rounds. So the interface is actually very, very crucial, very important. Yeah? All right. Next question, how can you encourage or convince the patients that telehealth care offers the same level of care or services compared to the traditional face-to-face consult?
I think it goes back to the original statement I said, right? Which is providing them the information that they need. In the clinic setting, you are able to walk up to the clinic counter and ask whatever question that you want. How long do I have to wait? What can I do in there, etc. Right? And those are the things that you want to look at replacing or improving on the digital health experience. Now, the thing is, it might sound better from a business perspective because you have very short blocks, less people in your hospital for it.
Right.
But never try to steer your patient to this. It is let them make that decision. All of us are now in post-pandemic or endemic stage. Right now, everyone can come to the hospital again, right? So allow them to make that decision for what is their preferred pathway of care that they want. If they want to do telehealth, let them do that. If they want to do physical consults, let them come to it. Probably after the first time they've come to the hospital and they had to wait 3 hours to see the doctor, they're going to say telehealth is the better option.
Yeah.
Like